Okay, thank you, Dr. Mahalik, for that introduction. As she mentioned, my name is Gage. Who's ready to learn about drug delivery vehicles? Got a couple? Okay. All right, we're going to start with a little outline. There we go. Okay. So first we're going to start off with a brief introduction. After that, we're going to move on, discuss the history of the development of drug delivery vehicles. After we get a little background in that, next we're going to be talking about a couple specific types of drug delivery vehicles. We're going to follow that up with a little discussion on methodology used to optimize and characterize them. Finally, we're going to end up with a conclusion, a couple main takeaways for you. All right, so first the introduction. What are they? Who do they benefit? Who's researching them? So what is a drug delivery vehicle? First, let's define a drug. A drug is a molecule that imparts a therapeutic benefit to it. A drug delivery vehicle is going to be basically something that makes that drug a little bit better. Perhaps it won't require as much of a dose. Perhaps you can dose less frequently. Maybe it reduces the side effects. Which drugs are going to be good candidates for delivery vehicles? Drugs that are poorly soluble in water. Poor water solubility leads to low bioavailability. I got a pretty basic graphic up there kind of showing that. Maybe your drug has a delicate structure. You want to protect it from harsh environments like stomach acid or perhaps enzymes floating around. Maybe your drug has negative side effects and a specific target. You want it to go to a certain area of the body, and you want it to leave the other cells alone. These are all drugs that can really benefit with improvement through a drug delivery vehicle. So, who do they benefit? Basically everybody. At least those using over-the-counter drugs. A couple examples, maybe you use a 24-hour allergy medication, extended-release caffeine tablets for students. And other, basically any of the over-the-counter drugs these days, they do benefit from a drug delivery vehicle. We also have, maybe you wouldn't guess it, but cosmetic industry. They always like to have the new and improved products. I have up there a little picture of a silver nanoparticle toothpaste. I'm not sure what that would set you back, but I imagine it helps you improve your dental hygiene. Now, of course, who stands to gain the most from drug delivery vehicles? Medical patients, particularly those with pretty serious diseases like cancer, autoimmune disease. Maybe they have some other biological limitation that limits the way that they're able to absorb drugs. All right, who's researching them? Obviously, pharmaceutical companies. Of course, they love helping people and providing benefit to patients worldwide. Secondary motivator might be money. Controlled release formulations. Pharmaceutical companies can take drugs that are already on the market and create a controlled release formulation of it, pop an intellectual property patent on it, and enjoy 3 to 7 years of exclusivity rights. Two other forms that I have pharmaceutical companies researching up there. Biosimilar. These are drugs that have the same benefit as a name brand drug. The only difference is that in the clinically inactive ingredients. And biologics, those are very complex molecules created from living cells. And it might be interesting to note the Nobel Prize in Chemistry was announced this week, and it went to researchers working with directed evolution, which is a way to make these biologic drugs. Of course, cosmetic companies too, product differentiation. For instance, L'Oreal uses liposomes to deliver vitamin A into deep layers of the skin. I have up there a little picture of joint liposome lotion for whenever your joints are low on liposomes. All right, let's talk about history a little bit. The progress of drug delivery vehicle development can be described in 3 generations. First one ranging from 1950 to 1980. Second from 1980 to 2010. Third generation is where we're at right now, 2010 till modern day. So, The first generation began with the development of controlled release formulations for drugs taken orally. Prior to 1950, drugs taken orally, as soon as it was introduced into the system, it would all release right away, get absorbed. You would have a rapid peak, followed by a rapid fall in the blood plasma concentration of the drug. We're going to be talking about that a little bit more on the next slide. I also put up there no protection in stomach acid. This sort of limited the types of molecules that pharmaceutical companies could work with. They couldn't work with anything too fragile, really, at least if you're making an oral formulation, due to potential hydrolysis or cleaving from enzymes in the body environment. So pharmaceutical companies didn't really have much answers for cancer or autoimmune diseases. They presented too many biological barriers that drugs at that time just could not overcome. Okay, so come 1952, we got controlled release technology introduced by Smith Beekman of Beacom Pharmaceuticals. Of course, benefits that it brought along with it were you didn't need to take the drug as often, you could stay in that therapeutic range a little bit longer. Let me explain what we got going on in this graph here. So on the x-axis, you have time. Y-axis is the plasma drug level. This shaded gray region right here is the therapeutic region that you want your plasma drug level to be at. So this is just a graph of perhaps a hypothetical drug. It looks like it has a pretty short half-life here. You see this dotted blue line. You ingest the drug at time 0, and immediately the concentration level peaks, perhaps even a little bit above that therapeutic range you want. And just as soon as it reaches that, again, cross back through that, and you now need to redose. With the introduction of controlled release drugs, it allowed, at least in this example, the drug to stay in the therapeutic range as long as 4 doses of conventional release drugs. So how is the release controlled? 4 mechanisms were identified to control the rate that a drug is released. The first of those being dissolution. This is the most basic drug release mechanism. It's basically how fast the drug dissolves in your body. It gets absorbed as it dissolves. And the solution that they found up to overcome this drug release mechanism is various encapsulation schemes. So I drew a little cartoon here. You can see the outer coating is just an inert coating. If you've ever seen a drug formulation that says enteric coating on it, that means that the exterior coating of it is built to survive through the stomach acid and reach the intestines. So let's say you take the drug, this outer coating is dissolving, you reach the intestines, and the first drug dose is released. As the first dose is released, this brings you up into that therapeutic range, and then a little time passes as this inner capsule begins dissolving. So now the first dose has been in your system for a while. It's probably starting to decrease in concentration, and just before it gets beneath that therapeutic range, you get another dose of the drug, bringing you back up into the range where you need to be. You can see how a method like this can be used to reduce the amount of time that you need to take the drugs. Second method, diffusion. So this is driven by chemicals' desire to move from an area of low concentration to an area of high concentration. You see you have the drug encapsulated here in a semi-permeable membrane. High concentration inside, low concentration outside. As some time passes, you're going to get the drug attempting to equilibrate the concentrations and releasing to the exterior environment. Okay, I got 2 more for you. So osmosis, this is a little bit more complex of a drug release mechanism. One example that I found is Concerta, which is a controlled release formulation of methylphenidate, also known as Ritalin, a drug used to treat ADD. So the design of this tablet is actually pretty ingenious. It starts with an overcoating containing 20% of the dose. That's that yellow on the outside. See right here we have a laser drilled orifice. So as 20% of the drug enters your system right away. That layer is gone. Now we're stuck with a semi-permeable membrane that water can get through. As water goes through, it expands this green part. You can think of that kind of like a sponge. So as the sponge increases in volume, it pushes the drug up and out of the capsule through the laser-drilled orifice, controlling the release of it. The last one I'd like to talk about is ion exchange. So this is really controlled by the environment that the drug finds itself in. The little example I drew up here is a resin which is bonded to a negatively charged sulfonic group, which is ionically bonded to a positively charged drug ion. So let's say it's in a low pH area, a lot of high proton concentration, for instance, the stomach acid. Proton comes along, displaces the positively charged drug ion, takes its place ionically bonded to the sulfonic group, and the drug goes on its way to do its job in the body. Okay, this brings us up to 1980. By 1980, release mechanisms were well documented. Pharmaceutical companies began to get creative, developing different kinds of drug release vehicles. So I got two of the most common ones up there, liposomes and nanoparticles. There's many more, but we're going to be getting into that later. I also have protein and peptide drug formulations. They began to see applications for those. But as they came up with this, they began to realize that there is definitely limitations regarding those. We're going to talk more about those in a second. I have a picture up here of Doxo. This is a liposomal formulation of the chemotherapy drug Doxorubicin hydrochloride, and this formulation of it was released in 1995. So let's talk about why they wanted to reformulate that. We're going to start with a little breakdown of Doxorubicin. Once again, it is a chemotherapy, which is an anthracycline anti-cancer drug. And what it does is it prevents tumor growth, and it's also cytotoxic to the cell. You can see its structure here. I highlighted a planar aromatic portion in red and a 6-membered guanosamine sugar in blue. So how does it do its job? What it does is it messes with the DNA replication process. So as DNA is going through the process of replication, it reaches a stage called transcription. During transcription, you have an enzyme called topoisomerase II complex, and what that does is it relaxes the supercoiled double helix. I have a little picture down here. You can see that helix has a little space in between it, which allows the planar aromatic portion to slide right in between two base pairs. Another word for this is intercalating. Basically incorporates itself into the DNA molecule, stabilizes itself with that guanosamine sugar interacting with flanking base pairs, and as it sits in there, it stabilizes the enzyme, and the cell fails to complete DNA replication. So over time, the cell is unable to replicate its DNA. It's going to eventually die. So what's the problem, right? You know, we got this drug, it's doing its job, it's killing cancer cells. What could go wrong? Highly cardiotoxic. It doesn't just kill cancer cells, it kills whatever cell it can get into. So we got a side effect, a risk of dilated cardiomyopathy, also known as an enlarged heart. And the way that this comes to be is it's determined based on your cumulative lifetime dose. So doctors at the time of your diagnosis, they do like a risk analysis. You know, what's going to kill you first, either heart attack caused by taking too much of the drug or the cancer that may begin to spread. Rose and Green did a study in 2001, and they determined that the risk of a congestive heart failure incident had 5% chance of occurring when you've taken 400 milligrams per meter squared, By the time you reach a 700 milligram per meter squared lifetime dose, you're already up to 48% risk of having basically a heart attack, CHF incident. So they like to limit people between 450 and 550 milligrams depending on their circumstance. So how did the liposomal formula solve this problem? So it decreased the CHF for all the doses. You can see here 700 milligrams, only an 11% incidence compared to the 48%. And equivalent efficacy, it works just as well. So how is it preventing the cardiomyopathy? Turns out by encapsulating it in a liposome, it increases the size of the drug by about 100 times. And at that point, it's too large to penetrate tight capillaries in heart tissue. So it goes right past the heart. It avoids all that. You don't got to worry about that. Obviously, there's still some risk to it, but much, much reduced. They say that the lifetime dose of this formulation is, they'll give you up to 1,000 milligrams per meter squared of this drug, and they found that it has effectiveness up to that point. So it can't get through the tight capillaries in the cardiac tissue. How does it get into the tumor tissue? So vessels in tumors are considered leaky. Tumors grow very rapidly. They also lack lymphatic drain. So poor design and combined with that lack of lymphatic drain, it allows this liposome to accumulate in the tumor over time and do its job. Got a little cartoon structure of Doxil here. C is pointing to the doxorubicin, and that is right at the core of this, contained in the core. That is surrounded by a phospholipid bilayer. We're going to be talking about the structure of liposomes a lot more in a little bit. And A is a polyethylene glycol coating. Once again, we're going to be going into more detail on that in just a moment. All right, so the second generation created all these vehicles only to find out there's biological barriers that must be overcome for the drugs to be effective. So the first barrier that they identified was those protein, peptide, nucleic acid drugs I was talking about before. Due to their structure, they struggle to permeate cells, and they also are rapidly tagged for clearance by the immune system. So we're going to be talking about how we overcome that barrier in a bit here. Targeted drug delivery is the second one. And that's basically getting the drug where it needs to be, keeping it out of areas where it shouldn't be. How can we accomplish that? I drew a little cartoon down here. So you see a cancer cell has these unique receptors on it. With knowledge of those unique receptors, you can create a ligand that can be attached to your nanoparticle that binds specifically with those receptors. So that allows some active targeting, so to speak, of the nanoparticle. And over the course of the dosage, you're going to realize that it's spending a lot more time near the cancer cells if it has some sort of an active targeting like that. Okay, a couple more. So more than 40% of new drugs are practically water insoluble. Any drug to be absorbed must be present in a solution at the site of absorption in order for it to react. The one way to increase solubility of poorly water-soluble drugs is by using mixtures of oils and surfactants. However, this presents new problems. Maybe those have some side effects that you want to stay away from too. Another problem that brings is once that gets diluted in your body environment, very aqueous environment, the drug may precipitate out and it won't be able to do its job at all. So I have here a little chart of how they used to classify drugs based on their solubility and permeability profile. I plan to talk some more about this, but I'm a little bit worried I might go over on time, so we're just going to be very brief here. Category 1. These are drugs that don't really have much of a problem, highly soluble, high permeability. We don't need drug delivery vehicles for those. Now as we reach category 2, you see that these are still quite permeable to the GI tract. However, these are poorly soluble. So we have a couple of solutions. We'll be talking more about that later. Category 3, has low permeability but high solubility. And category 4, these are the drugs that we're going to be talking about the most. These struggle in both regions. You know, large molecules, very insoluble in water. How can we find a solution to get those drugs where they need to go? Now that we learned about the history, let's explore a couple examples of drug delivery vehicles in greater detail. So the first one to discuss is one that we've already mentioned, liposomes. This picture is pretty involved here. There's a lot going on, so we're going to be breaking it down bit by bit. But you can kind of see the overall structure. We got the phospholipid bilayer here. Some features of that are these polar head groups here attached to a fatty acid tail. Another word for that is amphiphilic. The molecule is both water-loving and it has a hydrophobic region too. So the hydrophobic region of two of these phospholipids come together and form that bilayer, and that is protecting this aqueous core from the external environment. So you see liposomes actually bring a nice blend. You can do both hydrophobic and hydrophilic drugs. As you can see, the hydrophobic drugs reside in that hydrophobic region, the fatty acid tails. If you have a hydrophilic drug, put that in the aqueous core, protect it from the external environment. Another feature of liposomes is you can have a wide range of sizes. As I noted there, most drug applications have a smaller than 300 nanometer size. You don't want to go too small, though, as I was just telling you about in the Doxil example. If it gets too small, maybe your drug's going to be ending up in some capillaries there you maybe don't want it to be. So this solves a couple of problems. It protects the drug from enzymes, the immune system. Maybe the drug was very small. It could get cleared, filtered out through the kidneys. So it solves those, but it brings with it a couple of drawbacks. The liposome itself is vulnerable to attack by macrophages in the reticuloendothelial system, liver and the spleen. And what happens is antibodies tag it for destruction through the macrophage, and it degrades the molecule. How do we solve that? Polyethylene glycol, as I mentioned before. Now we're talking about it again here, but I got a whole section on it, so I'll be going into the mechanism in greater detail in just a moment. Basically, what you can think of this doing for the purpose of these vehicles is it masks the liposome from antibodies and macrophages. This increases the half-life. It can be up to 45 hours. That some drugs have seen half-lives with the PEG coating on it. However, this also brings back another drawback. It may reduce the ability for the liposome to interact with its target. So not only do antibodies have trouble tagging it, it has trouble binding to the cell that it is targeting. Of course, we got a solution for that too. So we can put attachments on the surface of liposomes. You can have any number of ligands. We got a couple examples here. As you can see, it's very versatile. You can really get a ton of different stuff on there. One interesting thing to note that I found out is that you can combine these targeting ligands with an imaging agent to provide a theranostic function. That is a word that I did not know until yesterday. It means that the molecule can impart both a therapeutic and a diagnostic component to it. So and that's useful for, they have a little example there, an imaging agent that shows up in an MRI. Let's say your doctors are trying to track the progress of the tumor. They want to see if the therapy is actually working, if it's decreasing in size. You're able to accomplish that with this method. Next up, we got polymer drug conjugates. So water-soluble, biocompatible polymer backbone. What on earth is that? Let's break it down. Water-soluble basically means that it's going to be bioavailable. It's going to be able to be soluble in water, reach the environment it needs to be in. Biocompatible, non-toxic is a synonym for that. Polymer, we got many repeating units linked together to form this backbone. See the arrow pointing? That's that guy, right? It goes all the way down there. So polymer drug conjugates can actually feature two types of targeting. Passive targeting is accomplished with the enhanced permeability and retention effect. What this means is that tumors are highly permeable. As I mentioned, they lack lymphatic drain. This allows them to accumulate in that area, and another word for that is passive targeting. Of course, you can also attach targeting moieties that will do a little active targeting, bind to those unique cell receptors as I showed you in the cartoon. Drawback, of course, drug load's a bit restricted. You can only attach so many drug molecules before you begin to encounter steric hindrance. They don't want to be too close to each other, so you're limited in that aspect. Let's look at the structure of one of these guys in a little bit more detail. All right, so we got an example up here. You don't got to worry too much about what exactly this is. I'm not even fully sure. But importantly, it does have all the features of a polymer drug conjugate. We got the polymer backbone, which I extended with some lines here to show it can go on and on. We have a degradable spacer. This moves the drug a little bit away from that backbone. It allows an enzyme such as azoreductase to swoop in, cleave the bond, releasing the drug into the environment. I have there's a couple other groups attached there. Perhaps those are they're on there to increase the solubility, or maybe they're targeting moieties, help the drug find where it needs to go. Okay, the next one's my favorite. We got dendrimers. So I picked to talk about these because they look awesome. As you can see, they are highly symmetric. We got a bunch of branches coming off of the repeating units. And these branches, they participate in a lot of hydrogen bonding, yielding a highly water-soluble molecule. And there's a couple different places where you can put drugs in here. You can accomplish a couple different things. If your drug is a hardy molecule, you don't got to worry about degradation or something like that. You can covalently attach it to the periphery. This is known as a prodrug, and it's released by getting cleaved, much in the way that you saw in the last slide, by an enzyme released from the dendrimer that way. Another way that you could do it is an ionic attachment to a functional group. And the third way is, if your drug is very hydrophobic, maybe you want to encapsulate it as a unimolecular micelle, enclosing that hydrophobic drug, protecting it from the aqueous environment. So let's take a look at how dendrimers specifically helped HIV patients. In 2008, an experiment was done to improve the efficacy of efavirenz and reduce its side effects. Efavirenz is an antiretroviral bioactive. This drug targets retroviruses. It has notoriously bad side effects, neuropsychiatric effects. This causes things like dizziness, blurred vision, depression, bad side effects. You don't want to be having those, especially if you have HIV. And it is virtually insoluble in water. A very hydrophobic molecule. Perhaps that is why it has such an easy time crossing the blood-brain barrier when taken in its native form, producing those neuropsychiatric side effects. So what did the researchers do? I got a couple other things up on the slide here. They conjugated it with a polypropylene amine dendrimer. That's that guy right there. Also very cool looking. And of course, because it's so hydrophobic, you could imagine it was probably encapsulated inside. Tufsin. What on earth is tufsin? It's a tetrapeptide made up of 4 amino acid residues, which features immunostimulant effects. You're probably thinking, Gage, why do you want to activate the immune system? You've just talked about how you want to avoid that, to avoid your drug getting destroyed. Turns out the HIV retroviruses, they like to reside in the macrophages. So in this case, you want your drug to end up in the immune system. So the tufsin attracts macrophages to it. They bind to the tufsin. They start encapsulating the efavirenz into the molecule, similar to a Trojan horse, I like to think. And after it's inside the molecule, the drug is able to do its job, reduce the viral load by 99%, significantly more concentrated in the macrophages than in other regions in the body, particularly the brain. So you don't have those nasty neuropsychiatric side effects anywhere near as much. So that made life better for quite a few people. Let's see what we got next, some carbon nanotubes. These guys are awesome. They are comprised of sheets of carbon, one atom thick, also known as graphene. You're able to attach it at a couple different angles, some names of some conformations of different angles, like the armchair conformation. You could imagine maybe it's a little bit flatter on the top at that angle, sort of like the arm of a chair. Also, chiral and zigzag are two other names that I found. These could be single or multi-wall, depending on what you want to do with them. And a great improvement that they have over liposomes is a much higher drug load. They are able to carry nearly 5 times more than the liposomes, pack a bigger punch, if you will. And you're able to coordinate attachments of ligands much better on these. As you can see, there's plenty of places for them to bind. Maybe if you want to be highly specific, you can have 2 different groups that really narrow it in and only allow it to interact with certain types of cells. Okay, so let's look at a mechanism of how these carbon nanotubes deliver the drugs. So loading and unloading. First step is getting the drug into the nanotube. One way I found to do this is covalently attaching the drug molecules to the inner walls of it with a degradable attachment. Other ways I've heard of are suction, capillary reaction, very complicated methods. You could imagine getting little molecules into a tube with the diameter of a couple of nanometers is quite a difficult task, and you would be right. The second step is they cap it with a biodegradable cap. They introduce it to the body. You can see we got those ligands on it, sort of like you saw in the cartoon. They're matching that receptor, bringing it right to the cell where it needs to go. So next, it's attached to the ligand. The nanotube then enters the cell through either an active process, transmembrane proteins might bring it in through endocytosis, or over time, its needle-like structure will work its way through that membrane. So we got that thing inside. Time to take off the biodegradable cap. Maybe that's attached with an enzyme that in the cell it can cleave that. Perhaps it's triggered by a change in pH, some sort of environmental trigger. Removes the cap, opening up the inside of that tube for interaction through the intercellular environment. That cleaves the bonds that the drug is attached to the molecule with, releasing it into the interior of the cell. Okay, lastly, we got gold nanoparticles. So in addition to being able to contain much greater density of attached ligands, they also come in some pretty cool shapes. One awesome application of those shapes is photodynamic therapy. So as I have those certain shapes produce heat when they're excited by light in the near infrared range. Particularly, you got the nanoshell and the nanorod doing that. So you could imagine you maybe get some targeting ligands on there. You introduce the gold nanoparticle into a tumor cell. You heat that area up with a near infrared laser. It activates the production of heat on the nanoparticle, killing the cell. Okay. Okay, next up, we got methodology. We're going to talk about a couple different ways that we can optimize, characterize different drug delivery vehicles. We're going to start with what I mentioned so many times before now, that polyethylene glycol. A word that they use to express attaching that is pegylation. So most new drugs present one or more of three problems. Large molecules are vulnerable to attack from the immune system. I had this graphic up before. I'll go into it in a little bit more detail here. Let's pretend these red guys are nanoparticles containing the drug that we want. It's in the blood plasma environment. These antibodies are also floating around. So over time they find your liposome or other nanoparticle and it bind to it. And much like the active targeting was being done with ligands, these are active targeters for macrophages. So the macrophage finds those antibodies, it binds to them, and it begins degradation of the molecule. How does PEG solve these problems? So it helps large molecules avoid attachment of antibodies by creating a very high degree of hydration. I have here 2 to 3 water molecules per monomer. You see this is an enzyme called uricase here, and this is pegylated uricase. You can notice quite a difference in the size of it. Now imagine 2 to 3 water molecules per monomer attached to all of those strands floating around there. You can imagine it as a nice mask protecting it. So, and also you can notice definite size increase. Maybe your molecule was very small, getting filtered out through the kidneys. And this size, perhaps the renal system will just bypass that and be able to have a little bit longer half-life than it would otherwise. And as I mentioned a bunch now, poorly water-soluble molecules benefit from the increase in hydration. You can increase the solubility that way. Let's look at a few variables in the process of pegylation. So pegylating molecules can be done in 2 fashions. Non-specific is an easier method in which you incubate PEG with your drug, and it non-selectively binds to the molecule. You're going to need to separate these by their physiochemical properties, because the problem that this poses is you're going to have a bunch of different half-lives depending on the size of the PEG. It's not something you want in a wide-release pharmaceutical product. So you can limit it with a couple different kinds of filtration, get specific sizes, but a more precise way to do it is specific binding, site-specific binding. So with the knowledge of functional groups and where they want to bind based on their properties, you can direct it to a certain area on the molecule. A couple other variables here, size and structure. I have the structure of ethylene glycol right there. And you see it turns into polyethylene glycol, that's the PEG, and this one has 4 units linked together. Modern applications use 80 units and higher of this, so it adds quite a bit of molecular weight to it. It's just a little graphic showing how it might attach to some sort of protein, something like that. And they can also be branched or unbranched. This is an example of a branched PEG molecule, where instead of being linear and all in line, it is popping off at different areas, kind of increasing its width, so to speak. You can get a little bit better hydration cloud that way. Modern pegylation leans towards larger, branched polyethylene glycol attached at specific sites. Okay. Lastly, I'm going to discuss a paper that came out in February this year. I did a presentation on in analytical chemistry on this paper back in the spring semester. And the authors asserted that current methods of screening for hydrophobic drugs didn't account for an important variable, where the drug molecule likes to hang out in the nanocarrier. So it turns out that some drugs, they hate water so much, they like to be in the hydrophobic core of the molecule. It's kind of hard to see. I added into this little graphic here some green. It's supposed to represent the drug. So this one that's all the way in the center here is going to be a very hydrophobic drug. Another place where the molecule can reside is at the lipid-water interface. So that means that part of the molecule is outside of the nanocarrier. It's exposed to the environment. In some cases that's desirable, others not so much. I have a liposome up here for comparison. You can see that the liposome features a bilayer, whereas these lipid nanoemulsions, just one layer. And these are what this paper really went into exploring here. So, authors developed a method to determine where the drug localizes in different nanocarriers. First, they passively loaded the drug into the nanocarriers by incubating and mixing for 72 hours, guarded from light. And after that time passed, they filtered off any undissolved molecules so that they had just a solution of the drug-loaded nanocarriers. Next, the amount of drug loaded is determined through ultraviolet spectroscopy. Ultraviolet spectroscopy is able to do this by first creating a calibration curve where you measure the absorbance of samples at known concentrations. After you're able to determine how the absorbance correlates to the concentration, you can then use Beer's law to determine the concentration of an unknown sample. So the unknown concentration of the low drug carriers was determined in this method, and that relates the absorbance to the concentration, so we know how much we got in each nanocarrier. Next, they used a process called photon correlation spectroscopy. A little bit more complicated of a process. My understanding is they bounce photons off at a specific angle, and they use that measurement to determine the size of the nanocarrier. See why that's important as they determine the localization of it. So what the authors did is they compared the drug load in particles of sizes 90 nanometers, 200 nanometers, and 400 nanometers. The lipid content, however, was kept the same throughout all three. What that means is if you have larger nanoparticles, you have less of them. Likewise, if you have smaller than 90 nanometers, you have a lot more of them. So with that knowledge in mind, they were able to come to the conclusion of where the drug is inside of the nanocarrier. An important sort of fascinating mathematical correlation that I really liked about this paper is how they related the surface area to the number and the size of the particles. So fewer larger nanoparticles have much less surface area than a ton of really small ones. So that's how they figured it out, actually. Kind of ingenious. If the drug load is similar among each side, they know that drug is it's right in the core of it. It's not exposed to the aqueous environment at all. Whereas if the drug load decreases as the size increases, you know that that drug is on the lipid-water interface, because with a decrease in surface area that comes with the larger size particles, you have a decreased surface area, you have less places for that drug to go. Okay, and a little conclusion here. By exploring the history of drug delivery development, I've demonstrated its medical significance. I showed you a few types of drug delivery vehicles This has actually barely scratched the surface. There are many more that are being extensively researched. And the third takeaway I want you to have is that they have innate customizability, and they can be modified to overcome various biological barriers. Special appreciation, Dr. Shea, my advisor, the chemistry department. Thank you all so much for teaching me everything I know. And peers and colleagues, of course, couldn't have done without you guys, and family and friends. Thank you so much for coming. A couple sources there for you. Thank you very much.
Thank you, Gage. We have time for questions.
Doxorubicin? Yes. Meter squared. And see this, I want to say that it is the surface area of the body. However, how they determine that, I'm not quite sure the specifics of that, but that is the unit that they were using across all the studies. That's the only thing that I could come up with. Dr. Guto, did you have a?
Oh, yeah. Going back to the history stuff that we had.
Sure.
We were talking about the coatings, I think, in the dissolving coatings and the diffusing, and the coatings they diffuse through, and the diffusive coatings. Can you tell us a little bit more about what kinds of materials they used and why they worked?
Yeah. So for the dissolution, what you're going to be wanting to do for like a capsule that releases the drug in a more slow form is some sort of like a polymer, something like that dissolves very slowly. Perhaps you even mix the drug right in it if you don't want those rapid peaks, and that way it can be released as the tougher polymer coating dissolves at a little bit slower rate. In the early 50s,
What did they start with?
I could not tell you for certain. One place that you might want to look to get that information, though, is there was a study that sort of really went over the history in the three generations. They went into a lot more detail of the specific materials that they used in the early days of the pharmaceutical research. See, anybody else?
Can you go to your first page of methodology?
Yes.
All right. Okay, what are the green dots? What are those?
Talking about these guys?
What are the carriers?
The carriers are the red. The nanocarriers are the red, and these are antibodies.
Okay, what are the carriers?
Are you talking about these?
I think he's asking what the small circles are. It's not direct.
Orange.
We have dots on the
Oh, I didn't put those on there. That's just part of the graphic. I think this graphic was describing the antibodies encapsulating like a virus or a bacteria, something like that. And that's just the shape that they chose. Okay.
So as far as the history goes, are we still considered being in the third generation?
Yes, that is correct. We're still focusing on overcoming those biological barriers. There's plenty of work to be done in that before I think that they'd come up with a new generation. It's going to be quite some time before they solve all those, I imagine.
When you were talking about, I think it was efavirenz, or was it delayed release or extended release where they use a laser orifice?
Oh, the Concerta?
Oh, okay.
Yes, that was the osmosis example.
That was pretty cool. It seems like a really sophisticated structure that they made.
It is.
Is that a common thing?
No, that is.
Mass produce something?
This was at the time really a blockbuster drug, they called it. It was very popular to prevent abuse of ADD medications. That methylphenidate is a stimulant. So this method, that capsule, the outer capsule was so hard that you could not break it up. It would prevent people from storing the drug, things like that, with this design of it. And the price showed how much technology went into designing this pill. It was a very expensive drug.
Is this mainly research that you've done in graduate school
I'm not certain of any. I mean, of course, you can do research as an undergrad. Some limitations you're going to find is the equipment that you need to formulate things, especially on the nanoparticle scale, is probably going to be harder to come by for undergraduates. Certainly, they are doing plenty of research on this at the graduate level. They have a little bit more access to funds, things like that.
So Gage, looking to the future, you think liposomes or would it be nanoparticles that would be leading into the future? Because I remember seeing statistical data that the liposomes have not been very successful.
Okay.
In the last 20 years. Doing your research, did you see any direction?
Great question. Yes, absolutely. They are trending away from the liposomes towards the metallic nanoparticles in particular. For some of the advantages that I mentioned, much greater density of attachable ligands, better coordination. The main benefit to liposomes is they're a lot cheaper to make. Okay.
So I think that when it comes to getting something inside the cell,
Due to the phospholipid bilayer, the hydrophobic part can maybe associate a little bit better with the membrane. Yes, however, the smallness of the nanoparticles doesn't really pose much of a problem in terms of cell permeability because they are so small. They are able to get uptaken just as efficiently as the liposomes. Yes. Yes, there's tons of research. That is one thing that I wish I could have spent some time on and talked about the toxicity. Different studies are saying different things. You know, they want to think that these materials are all non-toxic, and that would be nice. However, truth of the matter is that over time, especially carbon nanotubes of a variable length, those can accumulate in the kidneys. So you got to be very careful, and we need a lot more research before we're going to be able to actually bring something like that to market. Make sure that there's no buildup elsewhere in the body of things like that, unable to break down. Anybody else? Take it away, Zach. Thank you.